I'm Dr. Anita Clayton, Professor and Chair of Psychiatry and Neurobehavioral Sciences at the University of Virginia School of Medicine in Charlottesville, Virginia.
I'm Dr. Kristina Deligiannidis, and I'm a professor of psychiatry, OBGYN, and molecular medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell.
Our first objective today is to highlight the inadequacies of suboptimal depression treatment that's related to adherence, adverse effects, lack of efficacy or some persistent symptoms, polypharmacy in older adults, and first-line switching. Treatment resistance is also a problem, and these may result in persistent functional impairment and a poor quality of life. So what are the data? The burden of major depressive disorder and postpartum depression goes beyond the presence of symptoms because we see functional disability, and that can lead to economic costs. In addition, the symptoms and their persistence may be associated with comorbidities and suicide. Current MDD treatment inadequacies include poor treatment response or lack of efficacy, which we see in about 50% of people with their first-line treatment. This is really the primary reason for medication discontinuation. The second most common reason is acute and chronic adverse effects. Also, if people discontinue, they may not be prescribed another medication and so therefore go untreated. If we switch them without an adequate trial, we won't really know what's going on, or they may just continue on the medication despite the adverse effects and have a lower quality of life. Fewer than half of all patients are adherent during the acute and continuation phase of treatment. Finally, about 30% of people with major depression do not respond to their initial 2 treatments, despite adequate dose and duration of treatment. And those are then considered individuals who have treatment-resistant depression, or TRD.
Due to numerous gaps in postpartum depression identification and treatment, we have data that indicates that 85% of women with perinatal depression do not receive any treatment at all. Of those who do receive treatment, only 6.6% receive an adequate trial of treatment. So what we considered an adequate dose and trial of either psychotherapy or antidepressant. And ultimately, only 3.2% of women with postpartum depression achieve clinical remission of their symptoms.
So what are the challenges with regard to treating MDD and PPD with our current available medications? Our first-line treatments, such as SSRIs, SNRIs, and some of the unique antidepressants, often lead to inadequate treatment trials. Also, the onset is slow, and so if efficacy takes a while to be achieved, then patients give up before that can happen. We then see poor adherence, either due to adverse effects or they're not getting better, and often individuals are switched early before they've had an adequate trial, or they're switched to something that really isn't going to be different in terms of adverse effects. And so patients end up unhappy with their initial treatment. 60% of patients taking antidepressants experience at least one adverse effect during treatment. And these are difficult for certain patients to tolerate over the long term. Things like cognitive dysfunction, emotional blunting, weight gain, sleep disturbance, and sexual dysfunction. Continuing of the depressive symptoms on top of the acute adverse effects also discourages a patient from remaining compliant. And they often request a switch to another antidepressant. So I have patients who come in saying, I've been tried on everything. And it turns out when we take a history, they've been tried on nothing.